Hello and welcome to the latest BMJ COVID Unknowns webinar. Today we're going to be talking about COVID passports and certification, a very important and topical subject. We've got a fabulous lineup of speakers for you today, and I hope very much that you're going to enjoy the session. We've had a series of these seminars over the last few months. We're very grateful to George Davey-Smith for kicking all of this off with the marvellous editorial in the BMJ about COVID and the unknowns, the known unknowns, the unknown unknowns, which got us really thinking. And since then, we've held these regularly on a very interesting series of topics. You can find them all on our YouTube channel. Please do so at your leisure. We're grateful to George. We're also grateful to Alison Pollock, who's helped set this up. Also, my colleagues at the BMJ and several of the panelists who helped arrange this afternoon's session for all of you. So immunity certificates for COVID tests and vaccines are being presented to the public as essential to ensure public health safety and to stop transmission. However, the public health rationale for them is far from straightforward, and the evidence in support of them is currently lacking. Moreover, the digitization of certificates requires a complex global infrastructure which can be easily repurposed beyond public health, enabling new forms of tracking, data collection, and population surveillance and management. With private sector and government interest extending beyond public health, the question is whether and how to build digital infrastructures that serve public health. So we're going to delve into all of those themes and more over the next 2 hours. We've got a very active, I hope, Q&A session later on towards the end of the afternoon. I urge you all to put your questions into the Q&A box on this webinar, and we will either, if we can, answer them in the box itself or save them, and the panel will answer them at the end. So put your questions into the Q&A box. If you want to introduce yourselves via the chat function to each other, please do so. Please do that as well. Tweet about the session on Twitter using the hashtag COVID Unknowns, and it will be also available on YouTube after we've finished immediately to watch all over again and enjoy the presentations and the questions and answers that follow. So I'm going to kick off now. I think our first session, all our panelists are ready and present and available to go. And we're going to be talking about certificates and what are they for and how good is the science. We have with us Imogen Parker from the Ada Lovelace Institute. We've got Allyson Pollock from Newcastle University and Robert Dingwall from Nottingham Trent University. Our first speaker is Imogen Parker. Imogen, over to you. And you're going to talk about what are the purposes of certificates.
Thanks so much. And thanks to BMJ for organising this really great session. Imogen Parker, I'm Associate Director for Policy at the Ada Lovelace Institute. And by way of introduction, it's a research and public deliberation institute to ensure that data and AI work for people and society. We've been tracking COVID technologies across the last, I keep saying last year, but of course it's a bit longer than that now, last year and a quarter almost. And I've been asked to set the scene for this session. I'm going to be drawing on a few different pieces of work, but I'll try and cover that quite rapidly. So I'll just drop the links in the chat in case anybody wants to delve deeper. And I know full well you've got some really excellent speakers who are going to get much deeper on these issues. So just to kick us off then, in terms of what we're talking about when we're talking about vaccine passports, first should say that there's no perfect term for this. Different countries are taking different approaches, and that first link has been tracking how different companies and countries have been evolving across the last year. For the purpose of our work, what we've been talking about, and our study is very much focused on the digital tools that are trying to deliver these. I think there's a whole different set of ethical questions when you're talking about the paper-based version. But the components that we're talking about are threefold, I suppose. There's something about health status. So that might be vaccine status through a vaccine certificate. It might be test results. It might be proof of recovery or natural immunity. And we're seeing quite a lot of models that have all of those three in play. Of course, it could be something more dynamic or personalized, like a risk score, but most models are just focusing on those first three. The second part is linking that health status to the user identity. So how can you connect the person in front of you with that certificate? And some models, they're using biometric technologies, some are using being built into national identity systems, not something that we've got in the UK. You might use identity numbers or other forms of identity. And then the third part is around authorization through a third party for the purpose of allowing or restricting actions. And that's why passport isn't quite the right phrase, but that's why we've used passport rather than certificate in our work. It implies that someone wants to check this and someone wants to block you doing something or allow you doing something because of that. And for me, I think that makes this different to just a digital health record, for example. That might be at the borders, it might be at the pub, or it might be in an employment situation, for example. Of course, these aren't new, and under international health regulations, we've had smallpox until that was eradicated. There was cholera, typhus, which I think got brought back. And today there's still yellow fever. And in a lot of the public debates, it feels like where you are getting, you're getting a lot of analogies between that yellow fever certificate. You hear people saying, it's okay because we have yellow fever. So I just wanted to pull out a few differences to help shape today's discussion to that yellow fever certificate. I think the first is that most countries are going down a digital first route. They might be including a paper-based system, but it's really these technologies that have, I think, captured a lot of attention. There are certainly strengths to that, and I know that you're going to hear some of the examples of how this can bring more security, for example, more permanence. But it brings alongside a new digital infrastructure with it. And I think that was a really great introduction, Cameron, around thinking about not just the tool, but the infrastructure we're talking about. It's more permanent than paper-based, and it's also more adaptable in scope. So in terms of the information it might hold, the thing it might be proving, I think we need to think that through more carefully. Second aspect where this feels like we're in a different place to yellow fever is around international travel, but also domestic use. A lot of places we've seen using this in domestic situations, again, raises a different set of questions, I think, than just holding this at the border. And then the third point, of course, is that currently it's not backed by the World Health Organization. This isn't the same as yellow fever, at least not yet, as far as I understand it. So, and that's due to evolving evidence about transmission and concerns about inequalities. So just broadening out the discussion then of what we're going to be talking about today, in terms of what the benefits and risks are, why this has been such an interesting, attractive proposition for a lot of countries and companies. This then links to the second link that I've shared. We held an expert deliberation in January and February, including actually a number of the people that are on this session today, which I'm hugely, hugely grateful for. And we put to them across 2 days the question really of what place vaccine passports should have in society, if any. And just to pull out some of the benefits or the hopes for these sorts of tools, effectively the aim, the thing that people are hoping for is that you can have something that provides a more granular assessment of risk. And I think the message that we're hearing, particularly from the companies, is this might allow you to open up, societies more swiftly and more safely. I think that's a kind of top line around this. That might be because you can maximize freedoms in comparison to lockdown, boost economic recovery, and potentially some arguments we've heard around potential incentivization of vaccine take-up. I think those are typically some of the arguments that get put forward. In our expert deliberation, we spent most of our time actually really highlighting some of the concerns, the risks, and the unknowns, which I think is where that group ended up. And I'll just pull out a few here. There's a question around the public health benefit. So I don't need to be speaking to the scientific community, who are obviously really up to speed on this, but the unknowns around transmission, the way this might tackle mutations, and in particular, I think that question about how this might impact on real world behaviours or more collective forms, models of public health. Some of that felt like it was a real unknown and shouldn't be taken as read, that this is actually providing a more safe option than other more traditional forms of public health. Then there were a few particular harms that are worth contemplating, and that might initially just to the individual of this data sharing. So questions about how might this information be used. It might affect participation, of course. It might affect employment, might it affect insurance? And those sorts of questions will depend on the regime in which it's rolled out. Second, almost layer around that is how this might affect groups. How might this cut with or against existing inequalities? And just a few groups that's worth having front of mind, those who already face disproportionate surveillance, those unable to have a vaccine, people with insecure citizenship or insecure work. I think a particular group you might want to target in on to understand concerns. And then an even bigger layer of risk really is thinking about how what incentives this brings to a global picture. We've seen such stark inequalities between countries in terms of health and economic context. So this question around, could this supercharge vaccine protectionism? Will this create incentives for vaccine hoarding rather than sharing and potentially prolong the pandemic? And then the final closing point I wanted to make is about really whether, is this a tool for now, or is this something that might continue post-pandemic? And I think we've seen examples of surveillance technologies or crisis technologies being brought out in response to a time-bounded crisis. But once you build that infrastructure, does it normalize how things might be used in the future? So in the deliberation, we set up, I think, some potential benefits, but really weighted on those risks and concerns. And the final piece of work, which I won't go into detail on, was the result of an international call for evidence. What we did there is really try to pull together the evidence picture around the law, ethics, the purpose, science, where the science is, what we know about the public health, and also what we know about public attitudes and public acceptability. And where we came through with that is setting a series of 6 very high thresholds, I think, to rolling out these sort of technologies. In my mind, we haven't seen many governments or companies working through all those 6 steps. And I don't think we've seen that in terms of being confident that these technologies might be deployed in an effective way, in a socially beneficial way. But we've set out those high bars to try and, I suppose, challenge governments to really think through all the practical operational questions, the legal questions, the health questions, the ethical questions, as well as the technical and the socio-technical questions, to really understand the ramifications of building these type of systems and ensuring that if they are built, you have the right legal infrastructure and you have the right policy levers and backing by the scientific community. So I will leave it there. I hope I've just about managed to squeeze that into 8 minutes, but really looking forward to this event, and thanks again for the invitation.
Imogen, thank you. That was a really clear explanation of the many issues that exist and many of which we're going to address during the course of the session today. So thank you. We'll get back to you with questions, I'm sure, at the end. I forgot to introduce myself. So I'm Cameron Abbasi, Executive Editor of the BMJ, and I'm standing in today for our Editor-in-Chief, Fiona Godlee, but I'm sure everything will go swimmingly. Our next speaker is Allyson Pollock from Newcastle University, and Allyson is going to speak about, does the science support the public health purpose? Allyson.
Hi, thanks. I'm just trying to get my PowerPoint to work. Sorry, it's just coming. Sorry about this. Don't know why it's not. Yeah, here it is. It's coming now.
It's fine. While you're doing that, Allyson, it's really great to see that the questions are already rolling in. So thank you. We've had some very good ones already. Keep them coming. Thanks.
Great. Thank you. Okay. Hope you can all see. Great. And I'll turn myself off because you see me in the corner.
Yeah.
Great. Well, thank you very much. I'm going to focus today on the public health aspects and on the international health regulations, because these are really important. They were agreed at the World Health Assembly of the WHO in 2005. And this is the legal framework that defines countries' rights and obligations for public health events and emergencies that have the potential to cross borders. So I'm talking about cross-border travel, and they're legally binding on 194 member states. Now, the purpose and scope of these regulations is to provide the public health response to the international spread of disease in ways that are commensurate with and restricted to public health risks. And that's a really important sentence. And of course, it's a balancing act. You're balancing public health with economic, trade, etc., but also with human rights and fundamental freedoms. But in my talk, I'm going to focus on the public health risks and the purpose and scope of the IHR, which is so important because of their role in governing all countries. So clearly, the purpose of vaccine passes and test certificates for international travel are to prevent the international spread of disease by protecting countries from the risk of importing or spreading virus, and to protect individual travellers who may be exposed to viral infection. And this is very much what's set out in the yellow fever case, for example. So the first question is, do vaccines protect against public health risks? Well, clearly they do. And I've just put together a synthesis of lots of trials and papers that have been put together, and I've left the links here for you. And you can see that vaccines in the round are highly protective against individuals who may be exposed to infection, with 85% for a full course of vaccination, and really close to 100% for severe death, hospitalization, or death. But they're not 100% effective. So there will be individuals that will not be protected who may be exposed to infection. And when you multiply them up, they can come to several thousands, tens of thousands, or even millions. Vaccines are also fairly good against different emerging variants, although this is still science that's evolving, but they're not bad if you looking at the alpha, the beta, and the gamma. But actually, again, they're not giving 100% protection, and there's huge variation with vaccines, the vaccines themselves, different vaccines. And if you're unlucky enough to be one of these people who are vaccinated but then are infected, the effectivity, effectively preventing spreading the disease to others is only around 54%. But of course, most people will not be reinfected, but nevertheless, there is a cohort that will and are at risk. And the other big question about vaccines is we don't know about the extent to which they maintain efficacy over time. How long does a vaccine last in giving protection? So we've already established here that there are lots of groups here who are vaccinated who will still be at risk of transmitting and still be at risk of spreading and even getting the disease. So this is one of the first problems that you come to, which is this granularity, which Imogen referred to, because the logic of individual risk stratification is you then begin to add in other risks as well. And we know from other vaccines that age, immunity wanes with age. So do we add in age? And also we know that there are antecedents which make you more at risk if you are reinfected for hospitalization and mortality in long COVID, which includes obesity, type 2 diabetes, many other diseases, but also income, gender, even genetics now. So do we add these variables in if we're going through the logic of individual risk stratification? And if not, why not? And I'd just like to remind you that individual risk stratification is used very much in the US as part of population health management. It's become a big international trend where the logic is to pass the risks and costs to individuals against the logic of social insurance and solidarity. So you've already seen that there's huge problems now, that a vaccine does not mean as an individual you're not at risk of infecting or transmitting. It's just a reduced risk in the population, of much reduced risk at a population level. So then we come to the next problem, is which vaccines, what standards? I looked on the WHO website today and there are 287 vaccines in development. This is from the Tony Blair Global Institute report, which shows that there are 11 that have been approved for use in May. And here you can see different mechanisms of action for all these vaccines, which will mean they'll have different amounts of harms and benefits and efficacy. But the key to this is that they're not approved for use in all 194 countries. There's huge variation in the approval. So now we've got another problem: which vaccines, which are most efficacious, which doses, date of administration, expiry, and efficacy against variants. So many unknowns. And of course, countries all have their own policies for vaccination, which differ hugely, even within Europe. So then we now know that vaccination status doesn't translate into individual risk because different people mount different levels of immunity in response to the same vaccine. Efficacy can change over time in response to new variants, but it's different for different people. And the risks of reinfection and transmission vary by individual and depend on individual immunity, but above all, on the background population prevalence and other risk factors which influence that, such as seasonality. So then we come to the unvaccinated groups, and there's millions of people who are not vaccinated, especially low middle income countries, but even throughout Europe. So what do we do about those? Well, do we have tests of immunity, whether they've infected, or tests of infection? But again, we have this whole issue of how do we stratify public health risks for unvaccinated groups. There are many different groups. We've got people who've been previously infected with natural immunity, medically exempt, children and young people where the risk-benefit ratio is contraindicated, and also this important group of conscientious objectors who are often described as vaccine hesitant, but we must remember our history. The Vaccination Act removed the cumulative penalties, made it a voluntary activity, and introduced the concept of the conscientious objector into English law. But increasingly, you're hearing young people feeling that the vaccine pass is coercive and likely to become mandatory, and it's the only way they're going to have freedoms to travel. But let's look at the public health risks for those with previous infection. And there are several 100 million people now who've had previous infection. The interesting thing about this is that they have almost similar risks to those who've been vaccinated. So natural immunity is almost the same for vaccination. The durability of protection is good, and past infection confers almost the same infection as reinfection. And in the small numbers of studies that have been done, people who are reinfected tend to be asymptomatic and thus less likely to be transmitting. But like vaccines, we don't know how long the protection is for. So this group is in many ways no different from the vaccine groups. So what are they going to have? But the issue for this group is many of them will not have had tests. They'll have had a clinical diagnosis because there were no tests available in the early parts of the pandemic. So we come to tests of infection and tests of immunity. What's the evidence? Well, I'm dealing with the second point first, tests of immunity or past infection, which tests. Now, in this country, in the UK, most of Europe, there are no antibody tests available through government except for research purposes. So you would have to show you had a test, an antibody test at the time. However, as the WHO has said, there is not enough evidence about the effectiveness of antibody-mediated immunity to guarantee the accuracy of an immunity passport or risk-free certificate. And the same goes for tests of infection. Sorry, George, I've got to finish now. So we've got 3 imperfect tests, 3 imperfect measures, which do not provide clear or substantial evidence about risk. So the other big issue is, of course, COVID rates are falling, IFR is falling, and it's going to come to be approximate or be less than flu. So what happens? Do we abandon the vaccine passes, or are you going to extend that to flu and other infectious diseases? The other thing, just to make the case to end with, is that population measures are really important. It's very clear that countries should consider local incidence, the extent of immunity, local epidemic growth before implementing such restrictions. And the good news in the UK is population measures now mean that over 90% of people aged over 50 are vaccinated with second doses. And so we really have population measures which are important for determining movement across borders, and at the end of the day may be very much more useful than individual risk measures, which take us highlight all the problems and contradictions. So pandemic policies, such as the UK vaccine passport, that are sensible 1 month, may need to be rethought a month later, and it remains to be seen what the UK is going to do. Thank you.
Alison, thank you very much. Some really important issues you've raised there, and some very interesting slides. I'll be pausing several of those on YouTube later on. We'll get back to you with questions at the end, Alison. Thank you. Our final speaker in this first session is Robert Dingwall from Nottingham Trent University, and Robert is going to talk about, well, address the question of whether undermining medical confidentiality is justifiable. Robert. You may be on mute, Robert. Sorry, those dreaded words. We still can't.
Yeah.
Oh, there we are. We've got you.
Yeah, and you've got the screen.
Yes. We've got everything.
Okay, great. I'm going to be really quite quick on this because Imogen and Alison have covered so many issues. But what I want us to do here is to take what I've described as an informational approach, that to recognize that vaccine passports, immunity status documents, whatever we call them, they're essentially a means of transferring information from one person to another. Now, as it happens, I've spent a lot of my career working with people in the biomedical world, people in the public health world, but I also had the opportunity in the last few years to do quite a lot of work with computer scientists. And I've been quite fascinated by the different ways in which they understand information and in the ways in which they think about privacy. And I'm really struck by the fact that computer scientists seem to have a much stricter understanding of what constitutes privacy than the medics do. Medical confidentiality, it's traditional, it's sort of part of the scene, but it's also, how shall I put it, you give the information to one medic and the entire I was going to say brotherhood, but it's equally sisterhood, then gets to have access. Computer scientists tend to think that information should only be transferred on a need-to-know basis, and this is the spirit of the EU framework that we're still operating under in the GDPR. There's this fundamental assumption that if information can be misused or hacked, it will be. Any large database will have things done with it or to it that its designers, with the best will in the world, cannot envisage and might be appalled by. And it's also recognized that anonymization is much more difficult than most medical users of information systems assume. I'm very struck by the way in which the demonstrations I've seen where a very small number of pieces of information crack all the code that epidemiologists think that they've built in to anonymize the participants in their research. So immunity status is medical information that has traditionally been considered to be private. So what's the justification for departing from this principle? Does telling someone else my immunity status offer me any greater health security than not telling them? Conversely, does my knowing their immunity status offer any better protection to me? And I've put up this 2x2 chart here to ask really, in which box do immunity status documents offer any useful information? Either you have two vaccinated parties where the vaccine equally protects them, you have two unvaccinated parties who are sharing an equality of risk. In either of the other boxes, the vaccinated person is largely protected against serious infection. I mean, Alison's underlined the limitations of that assumption, but I think we could also benchmark it against the 30 or so other respiratory infections that humans suffer from. And I think unless that we can show that the vaccinated person who is exposed to COVID is at greater risk than, let's say, the person on, as we say in England, the person on the Clapham omnibus sitting next to another person on the Clapham omnibus in 2019 during the flu season, then we should be very reluctant to to ask for further revelations or for further information. So if the information is not of value to either party to an interaction, to whom does it have value? And that, I think, is a really important question, because and again, it's one of the things that I noticed with medics. They're very happy to collect information just in case. And again, it's a real difference with the computer scientists who are asking these hard questions about why are we doing this? Is it necessary? Is it essential? Is the value of collecting this information sufficient to justify the incursion on these traditional principles, whether we're talking about medical confidentiality or data privacy? And as I observed, I was one of the participants in Imogen's exercise. Unless you can actually demonstrate that there is a value added to the vaccinated person who is protected by the actions of the vaccine, by the impact of the vaccine on their immune system, that it doesn't seem to me that you have a justification for vaccine passports. It's not about communicating information to the unvaccinated. It's not about communicating information to the owners of a venue or the border control agents where you might be traveling internationally, and it's certainly not about communicating information to the worlds of epidemiology and public health just because they would like to know. And that, I think, encapsulates what I was hoping to say. So back over to you, Cameron.
Robert, thank you. That was very clear, succinct, and very helpful. Hope you'll be able to join us for questions at the end. So we've had a good understanding now what these certificates might help us with. We know more about the science that may or may not support their public health purpose, and now we've got some concerns about the confidentiality. Over to you, George, for the next session.
Great, thanks, Cameron. So we're going to go on to talk about what do digital certificates entail. And the first talk is going to be a double act between Daniel Sleat and Kirsty on the case for COVID passports.
Thanks, George. I think Kirsty, my colleague, will be bringing up the slides. Yeah, great. So I'll speak just for a couple of minutes about the politics of COVID passes, and then Kirsty will go into more of the technical detail on how they can be delivered. For my slide, I just wanted to very quickly make 3 points. For me, the political case of implementing a COVID pass is clear. Public support for COVID passes is consistent, while political leadership on the issue is confused, which means the government must lead on implementing a COVID pass and not be led on it by others, including the private sector. For the political case, it seems clear to me that there's no other measure viable for avoiding blanket lockdown measures in future than a COVID pass. In the UK, there's 65 million people. The highest number of daily cases we recorded was 50,000. So 3 times now we've locked down 65 million people for periods of time for the sake of isolating 50,000 cases. Those blanket measures can't be repeated again. If anyone else can think of a way to avoid doing that, then giving people the ability to show their testing status or vaccination status and why they don't need to be in isolation measures, then I'd love to hear what that is. Another reason why the political case is moving and is clear is because this is happening. COVID passes are being implemented in countries around the world. Israel and Denmark have implemented them. Internationally, they've been implemented. In the UK, we're going to use the NHS app to show vaccine status, and we'll be using the G7 to make the global case for recognizing those standards. COVID is not going to be disappearing anytime soon. There's a lot of debate at the moment on the June 21st date, but it seems clear that's going to be delayed for a period of time. We've published a paper earlier this year on the need to vaccinate the world strategically in 2021 with the rest of the global population at least taking until the end of next year. With that context, variants are going to be emerging over that time, and further waves of the virus emerging as well over that period of time. We need an infrastructure to deal with it, and the COVID pass seems the most viable way. Public support has seemed clear and consistent in recent months. A Comres poll said that 65% of people support a COVID pass, with different levels of majority support depending on the context. So 67% support for concerts and theatres, 65% for workplace, 58% for buses and trains, 56% for shopping. A recent poll by Surrey University said that 50% of people intended to use a pass both domestically and for travel, with only 20% unwilling to use one. Despite this clarity in public support and the public case, there's confused politics. Labour has said that they find a COVID pass confusing and discriminatory, although Keir Starmer has also said that he wants this to be the last lockdown. And as I've said, if anyone can come up with a measure that allows us to only isolate those with the virus and give freedom for those that don't, I'm very happy to hear. The government has said it has approved the NHS app for travel as a COVID passport. It's working with the G7 this week and next week on mutual recognition of that status. Michael Gove's in charge of a review for the domestic case, and Boris Johnson recently, I think yesterday, said that there are deep and complex issues around the pass. For me, a useful analogy of this is the travel testing, which the government has not led. It's allowed a private sector approach, and a cottage industry has emerged in which private companies are charging varying degrees of cost for a private test, different levels of standards, turnaround times, privacy. Not having government guidance and government lead on this has led to that strange approach of different levels of cost and how the testing is being implemented. To avoid that happening with the COVID pass, when it's clear that it's going to arrive anyway, UK companies like Saga are already implementing one, others are going to follow suit. The Euro 2020 England's group games are going to have a COVID passport with testing and vaccinations part of it. Since it's coming anyway, it seems common sense to me that the government leads and makes sure that the right framework is put in place. And Kirsty will explain how that can be done.
Thanks very much, Dan. Yeah, so Dan set out a bit why we think this is such an important tool to help us get out of the cycle that we're in of locking down to contain the virus and then lifting restrictions when they become unbearable, only to have the virus pick back up again. I'll talk a little bit about how we do that. The way we see this working is something like an app on your smartphone, which once you log in would enable you to access your data held by your GP or other NHS authorities, and enable you to show your vaccination or your testing status, and it could potentially also show immunity status, which is the way the EU and the Israeli systems work as well, if you got immunity by having a previous positive case of COVID, and demonstrate those through a secure live QR code to a verifier, which could be the passport control at an airport if you're looking to go into another country, could be a bouncer in a pub, could be the receptionist in a care home. Someone like that would be a verifier who would use an app to read the QR code, and they would see either a green or a red light showing no more information than the fact that you had met the requirements and you are at a reduced risk of transmitting COVID, and therefore good to go, good to enter the venue in question. That's the kind of sort of short version of how we see it working. There's a couple of really important sort of additional layers to that we think need to be integrated. One is to emphasize this point that it needs to include testing and vaccination. So we are not, with this use of a COVID pass inside the UK, advocating for any difference of treatment between people who have the vaccine and those who haven't. Having said that, those who are not able to get the vaccine because of medical reasons are likely to be a very small minority of people. there's evidence that the COVID vaccines are safe for those with immunocompromised conditions. So it's really people who have severe allergic reactions who are really at risk from the vaccines. So we're talking about a small proportion of people who would need to get tested regularly or continue to get tested regularly in order to be able to use their COVID pass. Most people will be able to access it using the vaccination status. So that's one condition that it's important to note. A second one is the fact that we see this as something that the government should facilitate rather than mandate. I don't think that we see a case for government to enforce the use of COVID passes within the UK, but we think that they should enable organisations, whether that's businesses, leisure settings, hotels, bars, restaurants, music venues, sporting venues, educational establishments, all of those, it should enable them to do it, should they wish to do that, so that they can provide some reassurance for themselves and for their employees, for them customers, that they are minimising the risk as far as they possibly can. Absent a bit of government support to make the NHS app usable by these organisations, you could see a proliferation of solutions, some of which would be paid for, some of which would not, some of which may have quite heavy admin burdens to use, some of which would be not as secure as others. We think it's much better that we have one system that is usable by everyone, and for that we need the government to support their use and allow organisations to use them. In terms of how we make that happen, the next thing to happen is that the UK through NHS needs to develop the functionality that they've already developed in the NHS app, so that it includes both testing status as well as vaccination status. They've said they're going to do that, but not yet when and whether it will include both lateral flow and PCR tests. And it needs to provide guidance and a verifier app or verifier functionality, so that those organisations, like I say, businesses or whoever that may be, can use it and can be on the verifying side of it. They also need to work with other countries internationally to get to an agreement of mutual recognition, so that your UK NHS app is usable in whatever other country you choose to visit, and vice versa. Those are sort of priorities for this. And before I wrap up, which I'll do very shortly because I know we've gone a little bit over our time, I just wanted to mention some of the counter arguments. There's rightly a lot of focus on the civil liberties and the privacy kind of consequences and implications of putting in place a COVID pass. I think some of the kind of ways to counter those worries are things like making it strictly limited to the COVID pandemic. I think having this tool would be useful for future possible epidemics that we might face, but we can easily put in place sunset clauses that mean that it is clearly an emergency measure, as are the lockdown restrictions, which are helping us to deal with COVID while it's still an issue. I think one of the objections we often hear is that we don't trust the government with this data. Well, this is data that's already held by the NHS, so that question is already kind of that's already the case. As to whether this is a thin end of the wedge and it would be we would soon lead to kind of proving all sorts of other health statuses, I think you can easily set out in law, and you should do, that it's specific to COVID. There is a vibrant civil liberties lobby, and rightly so, in this country, which I don't imagine would allow the use to expand. And I think the objection that we often hear, well, this would never be taken away. This is, we don't want this technology to come into usage because we don't trust future governments. I think that's a bit of a regressive argument. I think that's an argument to have better governments, not to hold back from using technologies that could, as Dan said, be really crucial in helping us get rid of the restrictions that are causing us so much economic and social pain, while still making sure we can keep a handle on the spread of new variants of COVID. I'll stop there, but really happy to answer questions.
That's great. Thanks very much indeed. Yeah, questions will be at the end. So I'm going to pass straight over to Michael Veale from UCL, who's going to talk about the digital anatomy of the immunity certificate infrastructure.
Thanks. And I'm sort of standing in here as well for my colleague Carmela Troncosco at EPFL, who is a computer scientist and unfortunately is unwell today, so can't do this presentation. I want to talk today about why digital vaccination certificates are themselves much more than just an app, and it's misleading a lot of the framing we've had around it. And in doing so, try to illuminate a bit of the technical anatomy, the digital anatomy of the entire system, both nationally and internationally, you might need in order to put in such a system, and why that has concerns that we should think about and address. So we see the EU and the WHO discussions of certificates. We see the word certificates come in a lot. That is the focus. We did, of course, with the Israeli Green Pass, which has since been retired. And we can ask ourselves why that might be. And there's a whole host, I think, of different reasons practically why that is not in place anymore. But the focus here has been on the word certificate. And therefore, it means we sometimes ignore what this actually might need to do as a system. So we've got a little bit of help through the EU's provided a bit more of a diagram of a journey. You have identification stages, vaccination stages, and importantly, highlighted here quite brightly, stages of when you've got a certificate that's been issued, and then the point of presenting a particular app to somebody. And it's at this point, I think we have to ask, well, we get lots of questions around what the result of this kind of entire system would be. And of course, ethical, equality, privacy, legal and operational aspects, but they're focused still very heavily on this idea of the app and thinking about the app as an object. What are you and are you not doing with this? And maybe what data is visible or not being made visible at this point. And we saw that today. The German health minister, Jens Spahn, held up his phone today and said that what we're trying to do is get this piece of paper, this static thing over here that you've crumpled up in your pocket, onto this device. And it's as simple as that, and that's why you should trust it. Well, this is where I want to outline a major misconception around the whole discussions of vaccination passports. And that's that analysing the certificates themselves is sufficient to ensure they do no harm. And this is illuminated by a consideration of some of the technical infrastructure as well. So when we think about harm, often it's thought about in terms of rights. Privacy is, of course, mentioned a lot, ethics and discrimination, rights to assembly and the like. But scholars of privacy and information are maybe, when they think about privacy within broader systems, it maybe differs a little bit from how people in the medical domain often think about privacy. So in a medical situation, when you're talking with your own doctor, you have a conversation that you believe does not leave that room. And therefore confidentiality matters. And sometimes confidentiality is an important goal. But privacy more generally, maybe it's a right to self-determination, a right to be left alone, to be free from some sort of interference and linked heavily to autonomy. Privacy of data is not a goal in itself. Privacy is often a means towards something broader. For example, prevention of abuse or democratic values that go beyond the rights of individuals. So these are things like freedom of speech, right to assembly, right to free expression, right to form your own opinions and to associate with who you like. And when we start to see privacy as something a bit more complex, we start to realize it's not just about the app, and it's not about data flows about the app per se. And we can see this by looking at the verifying system. So in this case, the verification request, which is just one step in this journey, you're putting a device on another device and it's checking for validity. It's at that point we start to see whether you're accepted or refused in that moment in space and time, whether you are whether your activities should, whether you feel your rights have been infringed at that moment. And at that point, it is not sufficient to analyze the certificate and whether the certificate only contains a small amount of data on the device, whether it was issued to enough people or not. The harms actually stem from what the verifier does. Does the verifier check, as Alison Pollock said, different kinds of expiry dates, different kinds of tests, risk stratification, other sets of data on that system? And who are these verifiers? Do they have the ability to reject you away from goods or services or not? And at that point, from a technical point of view, from the computing landscape, we can't technically limit our system to be one that only implements a yes or no and say that we've actually solved problems of ethics in society. When we look at the discussions from the certificate systems that are proposed by the WHO and the EU, they add lots of discussions to say, we are making these things, preventing discrimination. We're going to seek to make this as private as possible. But it's not within their gift. Because if you design a technical architecture that allows you to output just yes or no when you go up to a device, you still have these residual risks that affect the way people can access goods and services, associate with each other, and effectively work within society. And the problems we see there, I think, therefore go quite a bit deeper, and we're seeing a bit of a category confusion, looking to technical solutions and looking to privacy especially to solve a problem which it can't solve. There are clever ways using cryptography and privacy engineering to make it so that a verifier learns nothing except that the person in front of them meets a certain test, a threshold. But unfortunately, those ways still come with the harm that is residual from only having a yes or no system. So privacy actually can legitimize a system where the real harms are the yes or no button. So is there any hope that technology can help us control the certificates? Well, in many ways, technology can take us some of the way in adding safeguards here around privacy, and cryptographers and privacy engineers can take us some of the way, but they can't take us the whole way because the actual use is out of their hands. Now, we'll look in a moment about the hope of international governance around this. Because international governance may be okay if you're trying to govern the way a technical standard works, but actually governing what many, even millions of verifiers do and don't do, and what they check and don't check, is a lot more of a challenging task. The second misconception is that the certificates and the verifiers together create the system. So the system here, we've seen in the presentation from the EU Digital Green Certificate, or the Digital COVID Certificate. You see a QR code, it's checked, and it's signed to make sure it's secure, and there's some gateway for international travel and international sharing. But actually, the certificates and the verification that we see in that chart are only a tiny part of the system we need to analyze to make this even work at all and be trustworthy and secure. And that's often completely neglected. So we've got the apps, the operating systems the phones run on, what phones are and can and cannot do, even access the internet. The physical hardware, the verification hardware, and indeed, the many types of verification require you to be online at the time that you're going to be verifying the certificate. And when you're designing this kind of system, you are keeping a record effectively as you're checking a central database of who went to which place. It's not just a case of refusing or saying yes or no to somebody. Online verification, where you're checking to see if a certificate is still valid or not because it hasn't been withdrawn, has a problem of leaving a trace of everywhere that everyone in society has been. And if you're mandating that kind of system, you create many problems, obviously, of privacy and an unwillingness to engage in society that go beyond whether your medical data is being disclosed. It's actually your location trace that can be disclosed. It's very hard to prove this isn't happening or can't happen, especially at speed if you're designing the system to roll it out almost instantly. The human side of it is really important with the role of actually who is giving these tests, who is verifying they're happening. If you're giving a lateral flow test, a human still has to enter into a system that something happened, a positive or a negative test result occurred. Did you even check people's identity when they came to get a vaccination in the first place? If you don't, you have a big gap at this side of the system that can be abused. When you're allowing international recognition of certificates, how do you even know that the people on the other end were given a test correctly or not? They are who they say they are. There's one side where people say just show your passport when you show the app. The other side is perhaps the app is just relating to another person or data, different data entirely. And that's very difficult to protect against when you've got lots of humans in the system. And all of these systems firstly contain computing, where you need healthcare systems which actually have computers that connect to the internet, that connect to a similar system, infrastructure that works reliably when you've got a throughput of millions of people being vaccinated. This does not exist in many countries. Actually getting this done becomes a huge space of vulnerability as well as just failure. It has to link with ID systems where possible, and this is another part of the system which needs careful integration and is not something that you can spin off securely very, very quickly in many countries. And equally, the verification system, as I said, online, offline verification, each come with really important politics and policy choices, will affect the way people relate to these systems, whether they want to use them or not, and are deeply, deeply complex to get correct. This is not a technocratic system that can be spun up instantly. What are the consequences of this? Well, trustworthiness is really hard to achieve as a technical quality. It still depends on trusting people, trusting that people input data correctly. They don't input data for incorrect tests or tests that didn't happen, tests for people who weren't eligible or didn't receive them, vaccinations similarly. And when you've got millions of people, as you have to in this circumstance, who have to be allowed to input data and say, this event in the world happened, this is not something that is really easy to do. And we focus too much on showing an app, let someone or not enter based on the results of this app, without thinking this app may just contain junk data. The consequence is also the operation relies on digital health services that are not always ready. And the third one that becomes really important, especially for the international rollout in low capacity sectors, is that here you have non-democratic deployment, often by private sector companies, who will rely or set standards and have their own financial interests, especially when you have a system spanning across the world. When you have something rapid, in the case of the Commission did not even carry out a policy impact assessment as to this proposal for creating vaccination certificates for all 500 million EU citizens. And in the latter case, this is the GitHub page from the Commission's digital certificate code. We see lots of contributors popping in from many private companies, Deutsche Telekom, for example, contributing in a way which is very unclear. And this is within a fairly open system of the European rollout. You're thinking every single country you want to put this in potentially, especially largely unvaccinated countries in the global south, which, as Alison pointed out, may be a situation where this is maybe more justifiable when you haven't got the large-scale population level protection that you already have and that led Israel to seemingly let go of its COVID certification scheme currently. Then in these places, you have a huge number of private actors because the health capacity and digital capacity is so low. So the result of this is that there's a really high risk that you end up with an infrastructure that doesn't actually solve the problem it was built for. It was too late. It doesn't actually solve the problem as from a public health point of view, as Alison Pollock has described, or risks not doing so for literal just public health reasons. However, you have built an infrastructure that can be reused by the public and private sector. And you cannot technically prevent that in the same way that you can technically prevent some other misuse of infrastructure using clever computing technologies, because you can't protect and prevent what the verifier does with even just a simple yes or no tick. So in this system, we think about this more broadly, and we see this as an even bigger worry in the global south as well, in countries with limited rule of law, the countries which are not going to have effective legislation to prevent this, and countries which are not going to have the in-house capacity to define how this works, to deploy it in a way that is sane and can be dismantled, or have the finances to do it. So you end up putting something that might not work. You've relied on it being subsidized by private actors that have other incentives, and we don't know if it will be expanded, or internationally, who will effectively govern it. We see the WHO is already being disintermediated in discussions of this. There is no clear actor who can play this role, and it's already stepping into these shoes. So with that, I'll thank you very much for all of the other speakers, and looking forward to hearing the rest of the presentations.
That's great. Thanks very much indeed, Michael. Yeah, so now we have Seda Gurses, who's going to give us the next talk.
Muted. Can you hear me now? Hello?
Yes, we can hear you.
Yeah, great, fantastic. All right, I'll just kick off, and thank you, Michael, and I'll be building on Michael's presentation. A quick word about me. I'm a computer scientist working at Delft University of Technology. And while my main focus has been privacy engineering, my current research is also concerned with the social and political impact of computational infrastructures, which I define as the layers of digital think that connect us through digital space, like the smartphones, the cloud servers, the networks of sensors around us. Michael was kind of touching on all of this in his talk. These digital things create an information environment that captures and generates data that can be used to analyze behavior. I think we all know that by now. I also look at how companies like Google and Apple fine-tune this infrastructure through apps and software delivery. These companies can capture behavior and redistribute resources at scale. The objective of these tech companies is to massively expand their footprint in the world, and it's my contention that what they want is to become the global go-to infrastructure for solving any problem related to population and resource management. And I think this is where we meet the digital infrastructures. So while we may consider computational infrastructures just some sort of technology, in my work, I consider computational infrastructures as corporate assets. They provide global pathways of administrative control, and this is very relevant for public health, and they're used for optimizing the execution of policies for population management. So not just population management, but ways of optimizing them using these technical facilities. Now, with this background, I'd like to introduce you to an infrastructural view on immunity passports. When people think about immunity passports, they quickly start asking questions of data and data protection. I'd like you to think more carefully about the complex infrastructure in which that data circulates. My hope is that by drawing your attention to how systems that make processes digital do their work, by the end of this presentation, you will have a very different view of what vaccine passports do. In that context, I must add, the pandemic has supercharged the global status of public health, and this is relevant for the conversation. For example, it has empowered more international public health institutions like the WHO. Likewise, there have been calls for upgrading the European Centre for Disease and Prevention and Control. And the pandemic has also empowered the tech sector, which is riding high with trillion-dollar companies in search of their next horizon. Why move to integrate large-scale tech solutions into public health now? Is this the obvious thing to do? To answer this question, I'd like to draw your attention to the state of social trust. While global public health institutions and tech companies enjoy more power and influence than ever before, the public sphere is hemorrhaging trust. Many factors, including years of austerity cuts and public health funding, contribute to this, but the end result is tremendous vaccine hesitancy and the toxic spread of misinformation about the pandemic through social media outlets like Facebook. Don't forget, digital platforms are the conduit for the information pollution that is part and parcel of this pandemic. This is the social and political context in which immunity passports are being introduced. Global institutions and corporations riding high, people on the ground scrambling in confusion. Please note, technological solutions do not solve a public health problem. They only solve a public health problem in the context of this peculiar tension between high-level institutions seeking to act at scale and ordinary people mired in a dense and contradictory information environment. Now let's think a bit together about the impact of the passports on the public health system. Almost all of the discussion around vaccine certificates looks at what might happen to individuals and individual freedoms. Important, but I'd like to change the topic for a moment. Rather than focusing on how a digital passport system impacts on individual experience and outcomes, I'd like to focus on the impacts of implementing such a system on public health. How might computational infrastructures transform the practice and profession of public health? To make my point, I'm going to take the technical detail of the design that Michael presented for Carmela and show you how the design might unfold in a real life. Remember, the key elements of the vaccine passport system or immunity passport is you have a certificate token, so vaccination, testing, or recovery. You have an issuer of that token, so somebody gives you that token, and then you have an entity that verifies that token. So you show it to somebody. Kirsty talked about the bouncer, for example. And you're doing all of these things depending on the design, hopefully in a privacy-preserving way. Now, let me transport you to a specific venue in the real world to see what this looks like. Does anyone recognize this place? I mean, maybe you can put it in the chat. So this is Berghain, the world-renowned gay club and mecca of techno music in Berlin. It's so popular that club goers have been known to fly over to Berlin for on the weekends, even if they are not guaranteed entry. That's right, hundreds of people queue up to enter Berghain, and no one can be sure in advance whether they're going to get in. After a wait in the line, which can go up to 3 hours, the club goers finally arrive at the gates of Berghain and meet Sven, the bouncer. Sven is not any bouncer, he is the famous gatekeeper of Berghain. If Sven says yes, you can enter. If Sven says no, you bow down and hope that Sven will let you in another time. And if you don't believe me, you can go online afterwards and look for all the ways in which people tried to pass the gates of Sven. So how do vaccine certificates look here? So let's first look at why I have chosen this particular venue. I found it to be the closest example I could find of a pre-existing certification process that is not digital. When club goers come before Sven, they must show a sign of eligibility. Let's call it coolness. They know there's no outside institutional authority that certifies the cool. Sven is the only body that matters. He is the one whom you have to convince. Coolness might be pre-planned, but it is assessed in the moment on the spot. Now let's insert our digital vaccine passports onto this pre-existing certification system. While his original role is more complex, that of a negotiator or a decision maker, from the lens of a computer scientist thinking about immunity passports, Sven is the verifier. He verifies before you go in whether you possess the cools to go in. In doing so, however, Sven is not just practicing his personal taste in club goers, but he is enforcing the policy of the club. In the past, he has given some insight into this policy. Shortly, he wants it to be safe and he wants a little bit of friction for excitement in the club. When Berghain opens again and vaccine certificates are in place, however, Sven's job will change. He will no longer be enforcing only the Berghain policy. Instead, he will also enforce whatever public health policy is implemented in digital certificates. In the current situation, this is the vaccination testing and certification of recovery. What happens with immunity passports is that through the computational infrastructure, local control can be overridden by a digital policy machine that delivers and enforces. With a digital passport, the certificate tells whether a person is vaccinated, tested, or recovered. The issuer of the certificate is a public health authority. The verifiers at the doors of the Berghain is Sven, and the policy of the certificate is set by the authorities, not by the venue. From a public health policy perspective, this looks like a big success. The public health policy for pandemic that is valid across all kinds of venues and activities, getting Sven to comply is pretty straightforward. Perhaps more importantly, the policy can and will change over time. For example, future variants of COVID-19, a brand of vaccine becoming less effective, or the government losing a contract with a testing company, or discovering it's inaccurate, etc. With digital administration, changing out policies is no problem. Change the policy and the system will execute at scale. Yet here's the most important point. Neither Sven nor the club goers have any control over what is being certified. In a system like this, the issuing authorities set the terms and the infrastructure rigidly transmits and enforces these terms. This is a digital infrastructure, which means the content of the policies may be updated faster than Sven or the public can follow and evaluate. If Berghain adopts a system of controlling admissions when it reopens its doors, Sven will notice he has lost autonomy in his role. Is this a public health win? Maybe, but it may also be a Pyrrhic victory. What will be the long-lasting effects of utilizing digital infrastructures for the public health profession and the way it operationalizes its work? There will for sure be a shift in policy goals. With digital immunity passports, we're laying out a system that is made of checks. Proponents will argue that checks will incentivize people to vaccinate, yet incentivizing is not the same as informing. This technology is not a hand washing or keep social distance campaign. It is not designed with the direct objective of changing personal decision-making and enabling better health behavior. 2, without public communication as a centerpiece, a strong system of checks breeds the grounds for conspiracy theories and fuels distrust in public health measures. Rather than convincing local gatekeepers like Sven to comply, through infrastructure, we put a machine in his hands that compels him to implement a policy without ever needing him to agree to the policy. This impels gaming, the activation of a will to figure out and undermine the system. More importantly, from an institutional perspective, we're replacing public health professionals with a system that is enforced by the Svens of this world, who have no training in and do not see themselves as agents of public health. To give you a related example, with contact tracing apps in the UK, all of a sudden we had call centers full of 19 and 20-year-olds who had no public health training. Through the implementation of an app, the practice of contact tracing was remade in the image of Silicon Valley's model of gig workers. I will not summarize, I was going to just summarize it for you and just conclude. Digital infrastructures do not just deliver outcomes by other means. To advance their own ends, they bend fundamental power dynamics, shift the boundaries of professional authority, and torque the professional practice. Think of what has already happened with other professions like journalism and publishing. Facebook was supposed to be a content delivery system. It captured the operations and revenue streams of publishers, exploded the curatorial role of the editor, and implemented itself as a main source of daily news. The unforeseen negative consequence of this infrastructural change range from election manipulation through targeted messaging to a dramatic increase in misinformation and the intensification of organized violence around the world. Rampant vaccine skepticism is part of the social media effect. So following on that example, my questions to you are about the unknowns. What could a similar shift in the delivery of public health do to the institution of public health? Will we do a better job of protecting the core values of this institution than we did with media and journalism? In other words, what exactly is the vision of public health that these infrastructures should be made to serve? As the guardians of a legacy system, be aware that these infrastructures could supplant rather than serve you. You need to have a very strong vision of what you're going to do with public health before we unleash the power of these infrastructures into your practice. Thank you.
Thanks very much. That was fascinating. And the last talk from this session is going to be given by Rogier Creemers, who's going to talk about the Chinese social credit system in relation to COVID digital passports.
Thank you very much, everyone. And I have a habit of not using PowerPoint. I rather dislike using it, so I hope that my narrative, nevertheless, will be sufficiently interesting. And I was asked to provide a little bit of a sort of competing view from a country that really has been dealing with these issues the longest, but also that is already much further along the road in terms of building up this infrastructure of apps and practices, and that is, of course, China. And the really interesting thing is where it seems to me that much of the discussion that we're having here in Europe on vaccine passports is largely speculative, and we are very much sort of dealing with future telling, with prediction, or with forward-looking risk assessment. In China, what is happening is that we are dealing with a situation where, you know, vaccination is accelerating in China as well, but we already have an existing IP-enabled system of for COVID risk management to build on. And that is, of course, the traffic light apps, also known as the health code apps, that were developed over a year ago already, when the coronavirus pandemic started hitting. And this is really where we need to think about a couple of characteristics that do make China special, and also to a very significant degree explain why China has chosen or has been able to walk the path that it has. And the first is China's a developing country. And what it means to be a developing country is that there is a higher tolerance for imperfection in governance system, combined with a particular notion of risk management, which may well be described as solve your biggest problem first. And so what that meant was that from the get-go, the earliest iterations of these health code apps, and to briefly explain, these are apps that are based on self-reported assessment of symptoms combined with movement data and proximity data to other people who might have been infected through some sort of risk management algorithm. Comes up with a sort of traffic light system that if you're green, you're okay. If you are yellow, you're at risk and should quarantine for a week. And if you're red, you are very likely infected and should quarantine 2 weeks. Now, obviously, in the beginning, these apps didn't always work well. They were buggy. There were all kinds of questions on their functioning and all kinds of problems. Nonetheless, they were adopted, and partially they were adopted by governments, but most centrally, they were adopted by a society that was confronted with a pandemic risk, didn't quite know how to deal with it at that time, and frankly, given the responses here in Europe, I think we can safely say neither did we. And a society that exhibits a fairly high level of trust in technology. So already for a year in China, the traffic light system has been the de facto bouncer mechanism that Seda just mentioned in China. Very quickly, Chinese people became habituated to showing their health code app in taxis, in public venues like restaurants or shops, or when going to work. Now, obviously, these vaccines didn't. These apps weren't developed in a vacuum, and they're not implemented in a vacuum, right? They're implemented in a particular Chinese context, which came down like a ton of bricks on every suspected outbreak in China's large urban centers. And let's be honest, if we talk about lockdown being as bad as it was here, it's got nothing on China. And to a certain degree, the urban geography in China lends itself to it. Chinese people tend to live in blocks of flats, in residential compounds, which very often are walled and have 2, 3, maybe 4 gates. So it is really easy to enforce a lockdown where people simply cannot leave their building or cannot leave their compound by posting a couple of police people or sentries there. So this use of apps in order to monitor infection risk has to be seen in context with some of the very harsh measures to limit mobility and enforce quarantine that China has otherwise deployed. The second thing that we need to keep at the back of our minds is that China is indeed a very large country. I speak to you from the Netherlands. The city of Beijing has more people in it by itself than this country does. And so when we look at scale and the impact of scale on the Chinese efforts to manage COVID and use these apps, we really need to see China not as one country per se, but more as we would see the European Union. That's really the scale level we are talking about, and indeed, and then some. And as a result, many of these apps were used on a local basis. And very interestingly, once you left your city, for instance, you're in Shanghai, you go to Hangzhou, which is the next big town. It's about a 2.5 hour drive. And you came back into Shanghai, automatically you'd go into red. So they were sort of, you could call it fail safe, certainly a very strong sense of risk management there. So these apps have been widely adopted and indeed regularly improved over the course of the last year. Many of the issues have been dealt with. To what extent they are, we currently, unfortunately, do not really have a lot of research on that widely available in English. I do speak Mandarin, but it takes a fair bit of time to sort of go through all of that and assess what it actually says. But the other thing is also, it's not that Chinese people do not care about privacy. In fact, there's a fairly strict data protection law working its way through the Chinese legislative process as we speak. But in the sense that, as we saw in the previous presentation, privacy is very much not a goal in itself, but it protects other things. In China, this sense of privacy has been strongly combined with, has been strongly confronted with the notion that there are other things that are more important, public health from the collective level, but also the ability to take part in social or indeed professional life from the individual. And so, although there have been some concerns about privacy, data use, and security in these apps, generally we see that Chinese population has broadly accepted them. Obviously, one thing that needs to be taken into consideration there is that the Chinese government here is very much acting as the Leviathan in the room and has signaled very, very clearly that anyone ever caught red-handed with abusing coronavirus related data will face some very unpleasant times indeed. Now, how does that combine with vaccines? And this is where I want to conclude. All of this has already created a basis, right? The apps are available. The adoption, the broad adoption of the population is already it has become accepted under the population. And indeed, all of the population has been getting used to using these sort of apps in order to manage risk with people taking part in public life and indeed in professional life. The vaccine information, in that sense, is just going to become another variable in this process of risk assessment. A last thing that I want to throw in there is the role of the private industry. All of these apps have been built by Chinese private companies in collaboration with government. Interestingly enough, without the passing of billions to Tory party donors. And, you know, in as much as we might decry, and justifiably so, some of the aspects of Communist Party governance in China, one thing that they've been able to do fairly effectively is harness these private industries into what we can call Team China, where it is very clear that in matters of national crisis, unlike Facebook aiding and abetting an armed insurrection onto the capital, these companies, it's been made very clear to them that they're going to be on Team China and they're going to damn well behave as it. So that from a sort of op-ed perspective on what's happening in a completely different system, but nevertheless one that through the choices that it has made and through the processes that are happening there can shed some insight into how a system like that can work in practice. Thank you very much.
Thanks very much. Really fascinating talks in this session. And I'm going to hand over straight away to Alison to chair the third and final session.
Thanks very much, George. So I'm going to pass straight over now to Lillian Edwards, Professor of Law at Newcastle University, who's going to give us the framing on human rights and civil liberties for a few minutes. Thank you very much.
Right, I can probably catch up a few minutes as some of what I've got to say has already been said above. Many people have rather cogently argued that the problems we're facing with vaccination passports may be more on the international, global and infrastructural level than the effect on individual human rights, such as privacy, freedom of expression and freedom of assembly. This was also canvassed by the speakers from the Tony Blair Institute. However, this is what Alison asked me to look at, so I'm going to talk about it briefly. I'm also going to speak not from a global perspective, but from the perspective of a UK private lawyer. And I think from our perspective, when looking at governance of vaccination passports, there are three scenarios that are really quite important to disentangle. One is international travel, which we've spoken about a great deal, about the ability to move around the globe and so forth. My view is that from a UK governance perspective, we have very little clout here now. We are going to be subject to fitting in with the international schemes. We've already heard that it's being discussed at G7 today. We're going to have to talk to the EU. We're going to have to talk to WHO. That brings the focus of discussion down to whether the government can or should mandate the use of vaccine passports, for example, for entry to bars, gigs, theatres, stadia, etc. And then another question, which is how, if at all, should we deal with the issue of voluntary requirements for vaccine passports by the private sector, such as notably employers? So on the first, very briefly, Alison's already mentioned, it appears that after some consultation and some dithering from backbenchers et al., that the UK government, or Mr. Gove, has decided not to try to move forward with new law to mandate vaccination by way of public health regulations, or indeed, as some have suggested, it would actually need a new statute law, because the Public Health Control of Disease Act 1984 appears to explicitly say that that kind of move could not be done simply by delegated regulations. And thus, to bring in new legislation of this kind would involve protracted and probably quite damaging, I would imagine, debate in Parliament. And that's probably one of the reasons why the government's not keen to move that way. However, I think there was some celebration in some circles when Mr. Gove said on the 31st of May that they weren't going to go down that path. But nothing was said at all about the voluntary use of what we now have, the NHS app of some kind of vaccination passport framework by non-government operators. And so this takes me to what I think is really the core concern I've had myself over the last year, which is, would there be uptake by employers of a vaccine passport scheme to exclude those who might in other ways be disempowered or discriminated against? And one's thinking notably here perhaps of the gig economy, of minority wage workers, of workers of unsettled visa status and so forth, the general suspects, right? It is very hard to know a year on if this is actually something that employers have found attractive. We've got evidence either way. We did get some evidence from the vaccine scheme in Israel that apparently some employees there were terminated for failing to show the right pass. That's from the Lex Atlas report. The US seems to be jumping heavily as fast as its feet can carry it in that direction, but the US is very different in terms of employment law and norms. Whereas our own British Chamber of Commerce in fact, did a survey just the other week saying that they found that only 5% of UK employers were already doing anything about requiring proof of vaccination, and only 6% said they might in future. And certainly the anecdotal impression that I got in my own research, where we talked to universities as opposed to employers, was that there was no appetite at all to take on the aggro, the hassle, the risk, the potential data protection risks, the potential for court action associated with requiring rather than encouraging proof of testing and of vaccination. And I think the existence of a trusted NHS structure in this country had very much replaced the feeling in universities that they wanted to get involved in any of that themselves. So I've got about a minute, I think. I would just say, Alison wanted me to mention that if we were to look at ways of controlling the private sector and private use of vaccination certificates, the obvious place to look, and this is what I and my team wrote into the Coronavirus Safeguards Bill a year ago, would be to look to a traditional form of human rights proportionality scrutiny that is routinely used in Strasbourg and in UK courts using the Human Rights Act 1998. And this would require us to look and see, was the requirement made public and transparent? Was it in pursuit of a legitimate goal? That one would presumably be reasonably easy to prove, although maybe not given the first session. But notably, would the requirement of the display of a passport be necessary and proportionate to that legitimate goal? I think that one will be a toughie, given that we are already used to the idea that alternative measures are, if not sufficient, then certainly necessary. The masks, the distancing, the plastic shields, the controls on percentage of occupancy, et cetera, unless these were removed, which is a bit perverse. It seems to me it would be very hard to say that the imposition of seeing certificates was proportionate. The final point is to make that several people have emphasized sunsetting, and I agree that that is really perhaps the most vital brick in the wall here. How do you enforce it though? Again, a little bit of evidence coming out of Israel that although the Israel Green Pass has been sunsetted, this has not provided a guarantee that the private sector won't go on demanding it or something like it from their workforce. So I was going to talk about employment controls, but I can put that in notes or questions. But the last thing I would say is that there's much talk about human rights, good governance, and the rule of law in this area. It's important to note that good governance more generally includes the kind of things I've been talking about: transparency, accountability, the rule of law, but it also includes efficiency, that law should be efficient. It seems to me that this is likely to be the biggest control we will find on the spread of the use of vaccine passports in the private sector. And it is what we've already seen in Israel. When most of your population, I was going to say your adult population, but hopefully soon your over 12 population is vaccinated, then as was seen earlier, the risk calculus is such that why would employers or other private service providers want to start to incur the costs, the aggro, the bad PR, the possibility that their treasured employees will leave, the possibility of constructive dismissal actions? the possibility of discrimination suits, because there will be groups such as those by age or by religion or perhaps by pregnancy, by certain medical conditions, who will not want to or not be able to get the vaccine. Why would you want to run the risk of all these things when you could simply hope that the population is acquiring, unquote, first person to mention it, herd immunity by natural or vaccination routes? Okay, so that's my final point, and I would agree with the earlier speakers that therefore the worst risks here are not to individual rights, but probably to the creation of this outsourced public health infrastructure on a global basis. I'll stop.
Thanks a million, Lillian. That's great. Really good. And thank you for doing that. We're going straight on to Effie Fiona on the ethical limits to digital public health interventions.
Thank you, Alison. Coming later in the panel means I will probably have to repeat some of the comments that we already heard. But just by way of introduction, I am coming to this topic from the perspective of public health ethics and digital ethics. And I think these are two different angles, but they're very useful in thinking about those digital public health tools. So the digital public health ethics, of course, it has a longer history compared to the digital ethics. And initially, I think it was the generation of frameworks that aim to ensure a balance between the common good of population health and protection of individual rights. And the intention was to articulate the duties and obligations of the states. I mean, originally and still, the public health is in the realm of the obligations of the state and some other stakeholders, and also to articulate what constitutes ethical public health. Now, digital ethics is a younger field, and as we recall, it came into at least popularity due to what mainly happened in the private sector. Private sector began collecting, processing, and deploying technologies that potentially were harmful to individuals and communities. But although they come from different traditions and they address different problems, I think these two approaches in ethics, they do share they have overlapping moral space and principles that I think could be very helpful in addressing the specific questions. And it's from that overlapping space of principles that I want to raise 3 points, I believe, of relevance. The first cluster of my thoughts here are around the notion of and value of fairness. As long as we have many people who are not immune to this new virus, I think we will most likely need to be making a distinction between people who can transmit the virus and those unlikely to do so. Now, and the reason here is again based on other values like the well-being of individuals and that of the communities, but also the restoration of freedoms to those who do not bear risks to others. And I think it's really hard to justify continuation of restrictions of freedoms to those who do not bear risks to other people. Now, especially because this is going on for some time in this pandemic. Now, the fact that we have vaccines actually should make the need of this distinction short-lived, but the timeline really depends. And what is, I think, the danger here is to exploit the necessity of this distinction or manipulate it. And I think we have a bad record of justifying the thresholds we set for pandemic measures and for action. So, and I'm not going to say, well, these thresholds are political and I pretend that I am surprised, because we do know that public health is to a great extent also political. So what we know is that there is a need for that distinction. And even, you know, in Alison's presentation, we saw that this is quite complex. It doesn't take away the need for the distinction, I think, at least for a certain period of time. But we don't know is to what extent this distinction can be exploited or manipulated, and how actually to then become unfair in either direction. So the next set of my thoughts are around the value of equity. Equity is a serious consideration in decisions for any intervention, especially for public health intervention. And I think the question we need to ask, and this issue was raised already, is do these kinds of technologies improve equity or do exacerbate inequities. And I think here the real test is who is going to be harmed by exclusion through digital systems, by unfair discrimination, and from what are these people going to be excluded. We know there are people, of course, and this was mentioned already, that they have less access to digital systems or they are at risk when their identities are linked or cross-checked. But the further question, I think, is the global question. When we look at vaccination rates and the progress we're making right now, especially when we look at international travel, I think there we have a serious problem. We have very inequitable distribution of vaccines. And what can happen with deploying those systems is basically, again, looking inward, protecting some of our spaces here, and instead of trying to raise the global standard. But when it comes to equity, I think we do have some other unknowns, and I'm using Alison's call here to speak of unknowns and unknowns. And I will quote actually from an article that the deputy mayor of Jerusalem, Rachel Azaria, wrote. And as we know, Israel was already using the Green Pass long before we started the conversation here in Europe. So what she argues is that the public instinctively understood that more than anything, it was a way to nudge people to get vaccinated, not a way to discriminate against those who had received their doses and those who had not. So what she tells us is that discrimination was a real risk and one that we do not want to take. But what's more interesting is what she wrote next, quote, "The police and local authorities didn't enforce it, the Green Pass. Almost no one bothered to check them. Instead of dividing people into vaccine haves and have-nots, the Green Pass brought us together," end of quote. So we have no way to know that this is going to be how things play out elsewhere. Let's say in countries who tend to enforce the rules and the law they put together in more firmly. And I don't want to make a logical jump here, but if the Green Pass succeeded according to this description because it wasn't enforced, what is the lesson for us that are contemplating its use? And the last set of my thoughts are around the issue of legitimacy, which is another turn into what we heard already from Michael and Seda and others. My concerns around the issue of legitimacy and the legitimacy of the process that leads us to a particular public policy, but also the legitimacy of the actors that are involved in developing and deploying public health systems. So traditionally, of course, public health is the realm of the state, and so is its infrastructure. And we heard a lot about infrastructure and risks about developing that infrastructure the way it looks that it's going for those certificates. In the technologically advanced systems, such as those green passes or passes, we may need to be concerned about the new relationships between the state, those big tech actors, and the citizens. And we have seen, at least even in this pandemic, with the proximity and tracing apps, we had a flavor of what the big tech's role and power is, and the extent to which they were able to set standards that states had to follow and citizens had to accept. So we need to understand, again, these dependencies that we're seeing developing, and how big tech continues to reassure us, while big tech continues to reassure us that they take care of the ethics, that they do take care of fairness. And I was recently in a webinar that I heard the whole list of principles they're carefully looking after. But we have no way how this is done, and we actually never hear about the bigger issue, which is their role, the power they have, and how they exercise it. And I think Seda gave us a much more articulate presentation of that. So I think this lively discussion about certificates, what we've seen some development from some sort of enthusiasm in some circles, from the policies that the EU already is putting forward, for some other countries being cornered because they got to play with this international game. But I think we've got also some pushback, which is interesting. And interestingly enough, even WHO's almost not stopped pursuing the plan it had to develop this global health trust framework intended to store digital keys of member states. So IHR, of course, has not yet said that we can use that. Alison mentioned that, but also the technical standard that was supposed to be used for global consumption seems to be put on hold in that case. So in closing, I'm closing. I think that we know what we, I think, need to think more carefully as well in terms of legitimacy, given the social implications of making a digital check the condition of participating in social life, is to understand how the legitimacy of this process is going to be guaranteed, and whether that's a collective decision or a decision that's made on our behalf without our consent. Thank you.
Thank you very much, Effie. That was really brilliant. I'm just going to move straight on to Lynette Taylor, who's going to talk about disenfranchised communities. Thanks, Lynette.
Hi, thanks very much, Alison. So I started off thinking about this, wondering why the yellow fever vaccine hasn't created the same kind of debate as the prospect of COVID status certification. And it led me to reflect that the yellow fever vaccine is a practice of solidarity amongst countries, because yellow fever is not endemic in high-income countries, but you can get vaccinated for it there. So it's really about creating wide immunity and preserving it and drawing attention to its value. Whereas in contrast, the COVID certification we're talking about on this call today is unfortunately about privileging some people over others and individualizing the notion of immunity against all the evidence of the current science, as you pointed out, Alison. So yellow fever vaccination is meaningless on the individual level. I live in the Netherlands. I'm unlikely to get yellow fever here. We don't get together and talk about whether we have a yellow fever vaccine certificate or not in the pub. However, the COVID certificate, people do get together and talk about whether they have it, because it's super individual and it's about access to resources and mobility on the personal level. This makes it not a problem of minorities, but majorities, unfortunately. One issue here is children. About 20% of the world's population is under the age of 12. And if we look at, for instance, Israel, which has probably the most complete trajectory in terms of COVID immunity certification at this point, we saw that it had to rethink its Green Pass and the enforcement of the Green Pass, because no one had considered that children weren't eligible for vaccination when they set it up. So this child-family distinction shows us why thinking about generally reducing prevalence, as we do with yellow fever, is much more relevant to combating the disease than distinguishing between specific vaccinated and unvaccinated humans as they move around the planet. Although none of this is to say that people shouldn't be getting vaccinated. We don't want people who are infected with COVID being able to move around the planet, but possibly that includes all of us, even the vaccinated, as you pointed out, Alison, which makes it kind of confusing to think about how to do this distinction. Some of this, to be fair, is about policy leverage to get people to get themselves vaccinated. If people feel they can only go on holiday once they've been vaccinated, then they're more likely to get vaccinated. This seems reasonable, but what comes with that? By going with this system, we're essentially endorsing the claims of individual freedom over group solidarity, which are working against our ability to combat the disease. We need to have people observing public health measures as well as getting vaccinated, rather than putting their stake in the ground of individual freedom and brandishing their QR code on their phone at the expense of actually decreasing infections, which is what we're interested in here. There's also the issue of, again, not minorities, but the 82% of people in the world who already can't travel freely because they don't live in high-income countries. If anyone on this call is not living in a high-income country, they will know exactly what I mean. There are already massive administrative and logistical hurdles in place that stop people traveling from low and middle-income countries to high-income countries for education, business, to visit family. It is always hugely unpredictable whether anybody with a legitimate reason to travel can actually get a visa and then not get turned around at some point. And this certification system, if it ever actually functions, will add an extra and permanent layer into international mobility controls that will not go away with a legitimate reason to travel and probably a vaccination, ironically. It will discriminate against the credentials of anyone from a non-high income country in an even more structural way than already occurs. It will be harder for students to come to high income countries to study. It will be harder for people to visit family. It will be harder for people to travel for all kinds of legitimate reasons. And again, none of this is an argument that everyone should be able to travel freely right now because there is a global pandemic, which is incredibly dangerous. It's an argument that these systems will add a very powerful further layer to our already profoundly dysfunctional mobility control infrastructures around the world that are already enforced by airlines, border control authorities, universities, and employers, and a ton of other actors. If you add in this extra layer, errors will be almost impossible to correct. A lot of legitimately vaccinated people will not be recognized by the system. And this will not change. This will not be something that people can affect on the individual level. It will just make it harder and harder for legitimate travelers from anywhere outside the global north to be able to move. And finally, I would say that the technical infrastructure that is being built around this is in itself discriminatory. Because if you look at the tech specs for the system, if you look at the procurement process for the system that the WHO has put out a few months ago, they literally put in as technical requirements that global health inequality should not be increased and that access to vaccines should not be unequal. And here we have the hidden cost of this entire system, is that access to vaccines is unequal and global health inequality is existent and not going anywhere. And this system is going to cement those things. And responsibilizing technology developers for solving those problems only underlines that we have no plan to solve them any other way. Thank you very much.
Really very beautifully put and very compelling, actually. So could we, last but not least, we'll move now to Vidushi Marda from Mangalore. And I know she wants to have her slide shared. So Nikki, you're doing that, aren't you? Thank you. So Vidushi, are you all right? Are you there?
Yeah.
And you can just ask her to move to the next slide when you wish. All right. Thank you.
Yeah, thank you. Thank you, Alison, and thank you to all the excellent speakers before me. You've made my job incredibly easy because I get to go last and build on all the amazing points you all have made. So before I get into the slide deck, I want to say that the first time that I heard the term vaccine passports, I couldn't help but reflect about how that is such an advanced level or at such an advanced stage of COVID-19 response, because the idea of having a passport to authorize a certain access, whether it's travel or to get into your local pub, seems like it's 4 steps ahead of where most of the world is. And so I wanted to break down the idea of vaccine passports into how smaller aspects of the vaccination process and pandemic response layer on each other. Can you go to the next slide, please? So I find the definition from the Ada Lovelace Institute really helpful for this. So according to their May 2021 report, a vaccine passport consists of health information that is linked to identity information for the purpose of verification so that certain access or actions can be authorized. Next slide, please. I wanted to get into each stage of this in the Indian context, but before that, to give all the listeners some amount of context. India has been, as I'm sure many of you know, amidst a brutal second wave. We've seen a complete breakdown of health infrastructure, things like access to tests, access to medicines, access to oxygen cylinders, access to vaccinations. All of that has come to a complete standstill. We've also seen breakdown in governance because even the existence of vaccines or clarity about how you can access vaccines has been difficult even for the most elite. So I don't even want to go into the 99% of the country that suffers on a daily basis in terms of having access to proper governance, but especially in the COVID-19 context, I think that has consisted of a breakdown across the board. Of course, India is a population of 1.3 billion people, but what I want to underscore for the rest of the talk is that we have a significant digital divide where a smartphone is more often than not a luxury. It's more often than not an individual device, but rather a household or, you know, a community device. And that kind of has specific implications for the rest of my talk. Can we go to the next slide, please? So the first aspect of that definition of vaccine passports is, you know, having health information. And like I said, even the idea of having, you know, a digital vaccination passport that talks about health information would require that people are vaccinated, that there is some sort of record of healthcare. But, you know, in terms of procurement, just signing a purchase order from the central government to, you know, a big pharma company to order X number of million vaccines has been a problem during the pandemic. And so I can't help but think that the idea of having an app and having an API that you can build on is kind of 10 steps ahead of very basic, fundamental, rudimental issues that we're facing on a daily basis. The app that is currently, you know, envisioned by the government is called CoWIN. It's a registration and vaccine tracking platform. A couple of hours ago, I saw some reports of a data breach and the health data of 150 million people being compromised. I am yet to see whether that is legitimate or not, but I have kept it within the slide and actually scrambled to add it in just to kind of underscore that there is, you know, as previous speakers have noted, a huge privacy concern when it comes to health data in India, also because we don't have a data protection law, and the draft data protection bill that we have seen has significant and wide-ranging exceptions for the government, which kind of bypass international standards by a long shot. What's also interesting is that the app itself, the government has no idea as to how much money was spent to build it. They actually don't know who built it because it was privately built, but it's been procured by the government and transferred to the National Health Ministry post-fact. So all of this is not to say that privacy is the main issue when it comes to, you know, having this portal or having access to a smartphone to use this portal. It's more like the premise of how we are conducting pandemic response is exclusionary and discriminatory in and of itself. You know, CoWIN is going to be downloaded on a smartphone, which most people don't have. Even getting access to a vaccination slot has been a huge task. I tried for like about 2 months on the CoWIN portal because, you know, it would either not work or you have like millions of slots that, you know, are blocked out by some sort of crawler that a few developers use and then kind of sell those slots in the black market to make money. And so the idea of having an app seems almost, you know, like not significant given the other issues that we're facing at the moment. Can we go to the next slide, please? So this is actually a big part of the puzzle within India's COVID-19 response, because India is home to the largest biometric database in the world. It's called Aadhaar. It came into existence somewhere in 2009, 2010, you know, without a legal basis. It's been used the reason it came into existence is to ensure efficient and accurate public welfare delivery in 2009. But over the last decade, we've seen it being used in extremely problematic ways to, you know, from an expanding kind of mission creep to even private actors asking for Aadhaar for, you know, access to basic services like, you know, paying your phone bill or paying your cable bill. Sometime in 2017, it was difficult to wake up and not have about 20 different businesses asking you to link Aadhaar to their services for quick and efficient know your customer requirements. In 2018, the Supreme Court said that constituted mission creep and that private actors couldn't require Aadhaar to be used. But what has endured from the time that Aadhaar has existed is the fact that it is exclusionary in really tragic and dangerous ways. We've had instances where people have died because their Aadhaar authentication that was based on the biometrics didn't match. And so they couldn't get access to grains or access to subsidies that they need to kind of live on a day-to-day basis. And it's kind of almost a joke in Indian policy circles, where the government says, we're not asking you to mandatorily link Aadhaar to a vaccination. You can use X number of IDs, but because the vaccination process is done by both private and public entities, with private entities often having the upper hand in terms of buying vaccines on time, having more privileged people being able to fund that process, being able to pay more for vaccines. It's the private actors who make Aadhaar mandatory, even though on paper it's voluntary. And that has been the case since the beginning of this as well. Can we go to the next slide, please? So on top of this, so I've talked about two exclusionary aspects of Aadhaar, and on top of, an app that is exclusionary, and on top of Aadhaar itself that is exclusionary, we had, the National Health Ministry saying that they're using facial recognition to ensure touchless vaccination process, which again is another deeply problematic technology that has been shown, especially in the last couple of years, to have a discriminatory impact on people. Facial recognition systems that have been used in India have at least by law enforcement up until now, have an accuracy rate of about 1% or 2%. So we're really layering one problematic technology on top of another. Can we go to the next slide? I know we're running out of time. I'm not even going to the...
Have a minute to finish off.
Yeah, okay, good. Yeah, that's actually perfect. So I'm not even going into the fourth stage of authorizing access to certain types of services, because we're so far ahead, and as you can see, the first three issues are so big. But one of the things that I did want to share was that I've been thinking about, if we're saying that we don't want this super technocratic focus for pandemic response in the face of arguments such as, India needs scale, we need to be quick, and our population is, far more textured than most other countries, and technology is the answer to that. I started asking myself, well, India has a fantastic record in terms of polio eradication for vaccines, and what worked then? So this is sometime in 2013, and granted it was only for children, but what has worked in the past? And actually it was really basic things that worked in the past. So planning the supply chain along with the WHO, local Rotary clubs stepped in, having micro plans where you really understand the community that you're trying to vaccinate, have social mobilization networks to talk to communities that are skeptical or scared. Most importantly, having some sort of organization and coordination at the governance level between governments and between local governments and the central government. Those are kind of the important things. And also, ordering vaccines on time, signing the purchase order, those are things that have actually worked. But unfortunately, like other speakers have noted, what we're seeing is that there's a hyper focus on some sort of technical solution because it seems like the answer, or a whole other conversation is to say that it's a huge data collection exercise that is going to kind of endure much beyond the pandemic. It's going to be used for a whole host of things that kind of will continue way after we get over this hurdle. But I want to leave you with that thought in terms of there's an assumption that technology is the answer, but I'm not so sure that that is the case. Thank you, and I look forward to the discussion.
Thanks very much indeed, Vidushi, reminding us that we've had good local outbreak control and other measures for a long time before digital technology. I'm going to now hand over to Cameron, who's going to facilitate and chair this session of questions. I'm sorry, it's a little bit shorter because we finish around 6:15, 6:20. Cameron, over to you.
Alison, thank you very much. And thank you to our chairs and all the wonderful speakers we've had. That's been a fascinating hour and 45 minutes. I promise we'll finish on time. Nikki is marshalling the questions, Nikki from the BMJ. And we still have several of the panelists with us, so that's great. We've heard a lot about the pros, but much more about the cons, should we fair enough to say, of vaccine passports and certification. Nikki, question number one.
Of course. So one question that came up quite frequently was about people who participated in vaccine clinical trials not being able to prove that they've actually been vaccinated. So how will these groups be dealt with in regards to obtaining a vaccine passport?
Yeah, good question. Who'd like to take that? Alison, you presented the science. Come on.
I'm going to ask George to come in on this one.
Well, George could come in as well.
But I think this points to the I mean, this is quite extraordinary that people who've taken part in trials, is this because they don't know which arm they've been in? Is that what it is? That's probably the reason. But again, as I could say, individual risk stratification isn't the way forward. Really, we need to. This again highlights the complexities of actually trying to implement passes and tests, because you're going to get so many of these contradictions that will come up all the time.
Yeah, great. Yes, Mike.
Can I add to that? We've seen particularly identity companies or digital identity companies try to frame this into an issue of security. Like you must not allow somebody who has not been vaccinated into a place, just like you must not allow somebody who is not the owner of this bank account into this bank account to see the information. But this is nonsense. As Alison says, it's not about that risk management. You need to think of things on a population level. And the narrative that you shouldn't allow people who have had a vaccine that hasn't been authorized yet by the EMA because it's collecting data for the authorization, not to just give them a green, if you want to give them a green pass anyway and say, look, you get into everywhere. The logic that would say that's a bad thing to do is the same logic that says we must have secure spaces. And the reason that logic is there is ultimately because these vendors of systems want to sell biometrics. They want to, their economy is in, they don't make money from vaccine passports. They make money from being able to secure spaces according to characteristics and that set of technologies. They don't make money from creating group level characteristics of a population. So it's really about that logic, and it really pervades. And I think that question hits the nail on the head of showing exactly how far that logic has gone into all areas, into medical discussions that make no sense as a result.
Yeah, I mean, thank you for that. I mean, Vidusha, you were nodding your head and you told us about experiences in India. Do you want to add anything?
Yeah, I mean, I think in general, it's useful also to think about the market for certain technologies and the market for like who has something to gain from saying that a certain technology is the only way to be safe or to make sure that your kids are safe and things like that. We're seeing, the private sector kind of driving what pandemic response should be, not just in India, but in countries across the world. And I think we're kind of swapping out the good old logic, as Michael pointed out, without questioning business models enough.
Great. I mean, George, do you want to come in, going back to the research point? It does seem rather peculiar that people who are public spirited enough to enroll in trials then miss out on being, if vaccine passports do come in being able to get a clean bill of health on the passport.
Yeah, no, I just have no idea what the rules would be in that case. I mean, presumably when they've been unblinded, they can, if they were vaccinated, if they were actually received active vaccine, then they should be able to receive a passport. And if they've been unblinded and haven't, they'll be receiving that. Yeah, I mean, there are some trials that are carrying on, keeping people blinded, even though they will ensure that they're being vaccinated. It's really powerful. It's going to be really powerful data scientifically, i.e. someone who has received placebo will actually now get the actual active vaccine, but they won't know when they actually received the active vaccine, if they received it first time round or now, and the people who received active vaccine who will be given placebo will be really powerful. But
this
it doesn't relate to passports.
It's just another example of a discriminatory measure, basically. And why individual risk stuff is really not very useful. But it's a very nice example. Yeah.
Good. Yeah. Thank you, Nikki.
I think sort of leading on from that, similarly, another question that came up a lot was to do with different types of vaccines being approved in different countries and how the international measures would work.
Yeah, I mean, this is particularly mind-boggling. With all. Again, Alison, you presented the data, but we'll just hold fire on that. Does anybody else want to chip in on that first?
Yeah, maybe.
Thanks,
I think,
Seda.
I'll take a stab at it from an infrastructural viewpoint. Basically, what these infrastructures do is they become gatekeepers for markets. And there have been some papers, for example, looking at whether whether the European COVID pass is actually kind of gatekeeping which vaccines are are considered legit and therefore, for example, affecting mobility, where, for example, in Hungary, Sputnik was widely used, and it's not clear what kind of mobility constraints that will cause even within the EU, because the Sputnik is not accepted by EMA. So when you build this infrastructure, what you're doing is you're creating a space where a lot of private actors will try to be part of the policy. So they will lobby governments to be listed in. And if it's a centralized system that can push this policy to all the agents, then it's a great place for market actors to start entering the market massively, right? Because if it becomes a requirement, then all of a sudden you have legitimacy with your pharmaceutical product or test product.
Yeah, unfortunately, that lobbying is something we don't often see. You know, end up trying to pursue that information through freedom of information and leaks and God knows what else. Okay, yeah.
Just wanted to, I agree with the comment, but I think sometimes we might be a little surprised at what's going on in reality, right? There is a theoretical risk, and then there is the people on the ground. And one example, I put this on the chat, and I think it was out of context, but while we do hear that it's going to be only vaccines that are authorized by the EMA, I can tell you that the official website of Greece says that we're accepting the list of vaccines that includes Sputnik, includes Sinopharm, which has not been approved by the EMA, a bunch of others, and among others, right? So the reality of the system on the ground can be very different because it's driven by very different concerns. So when I agree with the centralized script that can actually be very susceptible to the lobbying and everything, but we have to always think that it might not be matching the reality of people. And honestly, what I'm thinking, because of the confusion we're obviously hearing today in this panel about what is the science, about how is it going to be efficient, and how it's going to work and who's going to do it, we might go down the path of no enforcement or no way of have a system that it's not going to work anyway because of all these millions of issues that we put forward here. So anyway, that's the thought to the vaccine and choices.
Great, thank you. Alison, did you want to add anything? You presented all the data on this at the beginning.
No, I was thinking actually Lynette might want to come in on this one, because this is about the huge global inequities, because it's not just about which vaccines, it's also all about the unvaccinated, as Lynette was pointing out.
Yeah, exactly. Yeah, thank you. Lynette.
Yeah, I think there's multiple layers of problem here. And the fact that most people in the world cannot get anywhere near a vaccine is just one of those layers. So, even if we vaccinated everybody in the world who was eligible and wished to be vaccinated, we would still wind up with a system that was profoundly dysfunctional for all of the reasons that the other panelists are discussing. So I feel as if all of these things come together into a bit of a morass. I think, honestly, the technical dysfunction and the geopolitical dysfunction speak to each other. I think the two are not entirely unrelated. I think that we have no functioning system right now which works for every country in terms of regulating things that we find important. Enforcement has to be different everywhere, and verification has to be different everywhere, and it's profoundly contextual and local. And this system tries to flatten that out. And that's just one reason that it's unlikely to work, whether or not it's a good idea ethically. And I think it's not a good idea ethically.
Okay, thank you. Yeah, Michael.
So one thing to that, another type of dysfunction is the legal dysfunctions. The reason that Effie is seeing what she's seeing correctly is because the EU doesn't actually have very many powers in terms of public health. So a lot of what's happening at EU level is very performative and saying that we're going to restrict travel into the EU, but ultimately that's a decision often for national governments to make. And so you get these contradictions. So you get on one hand this flattening out, which sometimes is real, some technical standards, sometimes is total performance. Then you get national realities, and then you get all of this, which will end up in actually risks ending up, I think, in political explosion, treaty reform at the EU level after this, and really who knows what's going to come out of that in terms of actual public health infrastructures for the future, because that's a moment where a lot of other actors can get into this game, and we should be a bit worried about what comes out at the end of that process.
Yeah, exactly. Okay, some major issues you've raised, but I think we need to keep going, so there's still lots of questions and not much time. Nikki.
Yeah, of course. We've discussed a lot about the kind of problems in terms of the public health infrastructures. So what should be the characteristics of our public health infrastructures?
Who's brave enough to tackle that? Alison, you are.
Well, I suppose I go back to the basics of public health, which is really where Veale ended. And really having, this is, it's really interesting how we've forgotten how important local disease control and local public health management is. And it's almost been abandoned in favor of these global solutions for infrastructure. And one of the issues that we haven't talked about is, which Seda touched on, is the new agents for public health. They're not, we've seen this with Test and Trace in the UK, where the new agents were Serco and Deloitte and Amazon, and that failed disastrously. So it's something about, it's not rocket science. This isn't new. We've had centuries of experience in local public health management and control, just as we've had nearly a century of experience in vaccination and mass vaccination, which is the point that Veale was making. So we get very distracted, and it's very clear that this is about geopolitics and the digital infrastructures being used for something else. Anyway, that's a little stab. George, you might want to come in on the public health side as well, and then open it up to everybody else.
George?
Oh, it's not there.
I don't have anything very sensible.
Okay. All right. Well, very honest of you, George. Who'd like to?
Seda's got her hand.
Actually, I didn't see that. Yeah, you moved around on the screen. Yeah, over to you.
Yeah, no worries. I think what was really interesting was the earlier talk by Robert, I think, where he said computer scientists think differently about privacy. And I think, as people who are savvy to the computational infrastructures and both their financial impetus as well as their technical problems, I feel like there needs to be a lot more conversation and capacity building in public health institutions to think about what a healthy digitalization looks like. And then within that, I think we need to think about the fact that most of the digital infrastructures are global. So they like to propose solutions at scale and that, easily go for global ambitions. And we need to find a way of doing technology with public health, if we're going to do that, that also empowers the local and contextual possibilities that public health has to work with, right? And I feel like we're completely missing that in the discussion. And so a lot of digital public health capacity building, I think, is one way forward to make good examples that we can use against this very global shortcut solutions that we're seeing right now.
Yeah, great, thank you. Yeah, Lillian, over to you.
I can speak.
Sorry, yeah, Lynette, yeah.
Thanks. I think to follow up on what Seda said, I think what we're seeing here is a scaling up of the philosophy that health is an individual concern as well. I think that's one really important thing that these infrastructures do, because they are technological infrastructures that are dependent on policies that prize innovation and personalization. And this is the opposite of an individual problem, if ever there was one. It's absolutely crazy that we're relying on technology solutions designed to personalize health, whether on the individual vaccine level or more broadly, the discourse of personalizing health on the part of big tech, to solve a problem that is by its nature communal and a problem of solidarity, and of solidarity amongst countries as much as amongst populations. And I think that these two things do not go together, and we're about to discover really badly that they don't.
Yeah. Michael?
Yeah, just on top of that, there's a difference. When we think of standards in public health and international governance, people might think, is a certain treatment effective or accepted, and then there's a discursive discussion between regulators upon an agreed standard. That's not how standards work in technology and governance, because standards have this disciplining function. You can't be part of the network unless you function in the same way. Your computer just won't talk to my computer. So in fact, this is something that you almost need to wrap yourself round as an entire governance mechanism to get a hold of, because as soon as it starts, it is itself a bit like a virus. It actually just creates and adjusts everything to it through its path. And the logic of how you govern a system like that, how you govern standards and networks, is very different than when we think about international cooperation in public health, which is a lot upon agreement and consensus. And consensus in this sense is your system has to work with mine, otherwise nothing will work. And that's something that learning to govern that is a lesson we urgently need to do at a global scale.
Yeah, I mean, look, I'm hearing all this, but this is happening. I mean, we had, we know it's happening. We're seeing the news every day. another organization, another sports body, another country is saying we're going to embrace vaccine passports, vaccine certification. Daniel, who unfortunately had to leave, he threw down the gauntlet to all of us and said, this is the only way to get out of lockdown. Can somebody who can give me a convincing argument otherwise? I feel it's important to represent that question. So, it's happening. There's no other way to get out of lockdown. What do you say to that?
Well, of course, it's not the only way to get out of it. There are lots and lots of public health measures which we're doing.
Well, you sort of gave the answer before, but yeah, okay.
It's just the same answer, really.
Yeah,
we've got vaccination, we've got immunity, we've got local public health measures. We sort of conflate vaccine passes with all of this, and it's just a ridiculous notion.
Okay. Yeah. So I think we've got Effie and then proceed. Effie, did you want to speak?
Yeah, sure.
Yeah, okay.
So the question you asked, Cameron, I think is a really good question. And it seems to me that we do have the alternatives, the public health, the measures that are alternatives, but people have been having those alternatives for quite some time if they're the non-pharmaceutical interventions. They come together with the constraints, right, that I think we've lived through for a very long time already. So the question is, and I think one perhaps good thing that happened was, if you recall, initially the conversation was about vaccine certification. And we moved even at the EU level from the vaccine certification to something that to have include your green pass is not just the vaccine, it's also your test, and it's also your recovery certificate. I know Alison said you can't figure that out, and you're right about that, but at least it seemed there was an effort made to expand the alternatives to the vaccine. And I think, Lynette, to your point earlier about children, the non-vaccinated children, for example, in the model of traveling with some form of proof of something, it could fall under the no vaccine because we're not, kids are not vaccinated, but they can be tested. Which opens another big question of, paying for the test, and cost your travel costs so much money that you actually do not undertake the travel, and. But I think it seems to me that, that moving from the vaccine only to those alternatives was a good move, I would say, compared to what the tunnel vision we had originally. But it seems to me that for the time until we get up to speed, until we get the vaccination going to the rates that we want to have it, and we have some way to, calculate the immunity acquired from other means, I also think that it will be probably something that we'll have to deal with. And but I believe, as I said before, I don't think they're going to work, so they will be abandoned.
Okay, thank you. Seda, did you want? Yes, your hand's up, Seda.
Yeah, I think what we've been missing, when we were looking at the contact tracing apps too, people were given either the option of lockdown or going under surveillance, a lot of surveillance and going onto digital infrastructures. And I think these are really false dichotomies that people are being presented with. And what I'm really missing from the public agencies is a reckoning with how we got here and how we're going to ensure that in the long term, this is going to be done better. And instead, we're embracing the technologies that partially got us here. So what I mean by that is what the example I gave was Facebook and misinformation and the kind of distrust in public health in general is a result of some of these digital infrastructures. So what does it mean to embrace exactly these infrastructures which may further gut out public health institutions? And I find this really a kind of awkward moment where I think obviously these systems are going to privilege a few, and in the process they're going to really undo institutions in ways that we might not be able to control. So I hope that we give some better answers than let's just embrace this thing because it works, because everybody's pocket has a phone and we can just rely on it. That's like a hijacking of our imagination.
Yeah. Okay, I think we're going to have to call time on this. I'm going to go around the panel and give you 20 seconds to make a final statement on vaccine passports and certification, and then I'll wrap up. So first of all, I'm going to go to Alison.
Oh gosh, no time to get my thoughts together. Well, I hope what I've shown you shows that individual risk stratification really isn't a good measure, and it takes us into more and more complexity and more discrimination. And I think the real key question is why countries aren't following what they're legally obliged to do, which is the international health regulations, which are showing that these measures are commensurate with public health risks and proportionate. And that's where I think we should be taking the focus for international health regulations. As Lillian says, what countries do at the domestic level is a completely different issue. And of course, there are other laws on employment, civil liberties, human rights that may come into play. But I guess that's my 20 seconds. Let's look at the international health regulations and ask why countries like the EU are not actually complying with those regulations, which they're legally bound to do.
Great, thanks, Alison. Effie.
Okay, well, I think my comment is broader. It's not just for the certificates. I think this conversation is an opportunity, like it was the one for the contact tracing apps, to collect our thoughts and decide maybe how we move forward in the governance of digital public health tools. And that is overdue conversation. So maybe one thing that could come out of this mess that we are in right now is to determine what kind of governance is necessary for this kind of tools. We will see them, if not that one, a version of that a little later. So we need to prepare, and I hope through these kinds of conversations we can do that.
Thank you. Lynette.
Thanks. So first of all, I very strongly agree with Effie that we don't have the governance for this, but that has seldom proved a problem in the past. We tend to just bust on out, make things and see what happens next. Not always to our own benefit. I guess the main takeaway for me from this is that every moment that we spend discussing and building and failing at these things, whatever happens, is a moment that we're not focusing on the larger public health picture, which can actually get us out of this mess. You know, and it doesn't ultimately matter that much. We shouldn't do it. It will be a problem for anybody who's not highly privileged. It's a bad idea. But even if we do it, it doesn't get us out of the mess. We need to figure out what gets us out of the mess.
Thank you very much. Sorry, my cat's just arrived, calling time on the seminar. Okay, we'll move on. Michael.
I think there's, when we think of digital infrastructures, people often come with technologies. They say they're magic, they can do a lot of things, and sometimes they can. Sometimes they can do things privately, confidentially, but technologies always do more than one thing, and infrastructures that get built always can do more than one thing. And the skill that we need to develop is, how do we analyze that? We analyze and react to it as a society, and not be technophobic. It's not being Luddite and throwing it out the wall. It's saying we need a sophisticated understanding of what is happening, which actors are involved, where is this going, and how do we take control of it for the future to make sure it goes somewhere that's good for health, society, public health, what we're trying to achieve.
Great, thanks, Michael. Fiduci.
Yeah, I have two main takeaways. I think the first is that we need to question inevitability of technology of any kind, but specifically in light of the last question, I think, we can't take vaccine passports as a given, or, it's here, so we might as well optimize it. Some things are not worth optimizing. And the second is that technology cannot fix what governance or lack of governance has broken. And so we should try and fix things where the problem actually arises instead of papering over them.
Thank you very much. Seda.
I want to take some lessons from contact tracing apps, because I think the discussion is not whether vaccine passports will work or not, but what they enable in the long term. As somebody who worked on the privacy preserving contact tracing app, I can say proudly there was one win, regardless of whether it won or not. No government or private entity has collected our social network data, which was like one of our big wins. But where we did lose is that last year there was a big debate as to whether public health should run through phones and apps. This year, with vaccination passports, we don't have that debate. And the reason we don't have that debate is the contact tracing infrastructure has done its work. The app has done the work of thinking apps are normal parts of the public health institution. And so we need to be very, very careful when we ask for like differentiated profiles that Alison said somebody might want to ask as we individualize risk, that we're actually ingraining this infrastructure, because it does differentiation really well. So it's going to be, I think the way out is going to be through having a very strong vision of what public health looks like in the next literally 20 years, and to make sure that the technology serves that, not the other way around. So that would be my last point. Thank you.
Thank you very much. George, is there anything you want to add before we finish?
So I guess as as I started these with talking about known unknowns, this is one area where I really don't have a sort of strong answer, and I guess I think there can be sort of local situations where one can imagine some forms of certification which could be controlled locally, could be useful, and there could be international situations when they become purely discriminatory and ways of closing borders against people you don't who people want to keep out for other reasons. So I for the whole notion of this sort of credentials around immunity, I'm not certain that I don't have an answer at a level that would say that I would always be on one side or the other in terms of using any form of credentialed vaccination.
Yeah, thank you very much. I think, if nothing else, this has proved the fact, why we have a series of webinars about COVID unknowns. The unknowns we've thrown are rather considerable and lots more to consider. I want to thank all the panelists very much. It's been a really fascinating subject on a tricky area. Thank the organisers, George, Alison, Nikki and David from the BMJ. And all the participants, you've stuck with us. It's been a very valuable session. We hope you will join us again. If you want to watch this again, go to the YouTube channel. Do carry on tweeting about it and sharing.